Hi everyone, I'm Julien Dreyfus, imaging cardiologist in Paris, in France, and I have the great pleasure to discuss today with Khalid Shakfeh, who is a cardiologist fellow at the University of Florida in Jacksonville. So today, Khalid, we are going to discuss about a case report that has been just published in JACC case report and that you will have the pleasure to display and to present during the ACC Congress. So the title is Missed Kawasaki Disease Presenting as a Giant Coronary Aneurysm Mimicking an Intracardiac Mass. Could you summarize in a few words the case of your patient?
Yeah, so to make it brief, we had a relatively young man, 52 years of age. He was coming in with complaints of chronic chest pain, since his time in his 20s even. And he had a slight troponin elevation in the setting of what sounded like a TIA. And we just wanted to make sure we had a good cardiac workup for him, given everything that was going on. And when we got on our echocardiogram for him, we found that there was this mass that was had very similar elements to an atrial myxoma along the tricuspid valve. And so we were concerned that this may have been a potential component of the TIA that he came in with, not sure if it was really causing his chest pain. So we went ahead with additional imaging, cardiac MRI, cardiac CT as well. And we found that rather than being a myxoma, it was actually not one, but two large, greater than 2 centimeter fusiform aneurysms along his RCA that looked like a myxoma on standard TTE. And that was the basically going into it. And we were able to find out that perhaps this was the reason why he was having his chronic chest pain.
So in fact, you begin as usual with transthoracic echo. You were surprised by this mass, and that's why you moved to other imaging. And that's also one of the purpose of the publication, is to discuss about the benefit of the multi-modality imaging. So can you tell us more about the imaging modalities you use for this patient?
So to begin with our, I'll kind of give you the timeline of events we did, why we chose the imaging modalities at the time we did them. So on his standard TTE, it was a non-contrast avid mass, sort of compressing the outflow tract of the right atrium, causing what looked like mass effect on his tricuspid valve, preventing flow into the right ventricle. So, and because of those imaging qualities, we decided to do a cardiac MRI. And then that was the first thing we did after the echo. And then we did on T2 enhanced imaging, we found that this was, rather than being a atrial myxoma, that there was evidence of a partially thrombosed fusiform aneurysm within his RCA. There was one, a questionable second one more proximally. So that is when we proceeded with the CT angio of his coronary arteries, which we found both partially thrombosed fusiform aneurysms, and we were able to have a nice 3D reconstruction of it because of his CTA. And then finally, to sort of do pre-procedural intervention on it, our CT surgery team asked us to do a left heart cath. And the left heart cath, we were able to nicely visualize those large fusiform aneurysms along his RCA. And then additionally to that, he had ectatic vessels of his ectatic LAD and ectatic left circumflex arteries. So all of this, given how these were oddly shaped aneurysms, partially thrombosed, and that he's been having this for a long time, the addition of our imaging plus his clinical symptoms made us think that this gave us inclination that this was a missed Kawasaki disease from when he was much younger.
Yeah, that was my question, because finally you mean that you used all imaging modalities to make the diagnosis with CT, MRI, and also coronary angiogram. But
Correct.
define an aneurysm, it's not so difficult, but why did you think about the Kawasaki? How do you think about it? Because it's something that is not uncommon, but it's not always easy to think about it. Look, so why did you think about it for this patient?
So the things that really made us think about it were two things. One, because of how large and the quality of his aneurysms were, as well as the rest of his blood vessels. They were very, in general, all of his blood vessels were very ectatic. With the addition of these, fusiform aneurysms, and they were large. They were about 2.5 centimeters. There was one proximal in the RCA and one more distal in the RCA, where it actually would look like a mass compressing the tricuspid valve. It's for us, it was like, okay, well, that's unusual to have both of these at the same time. And then he was having these symptoms at a very, very young age. So we, there were times we were asking him, as one can remember, 5 decades later in life, if he was having symptoms of fevers or mucositis, those type of symptoms when he was young, and he couldn't recall. But that's what really made us think this is Kawasaki's disease. He had like elevated CRPs for a very, very long time, dating back even in our system in 2020. So that's why we're thinking, okay, that just all of that together points that to Kawasaki's.
And finally, after you made the diagnosis, what was your treatment strategy for this patient?
Ultimately, we felt that given that these are large aneurysms, the risk of sudden cardiac death or ruptured aneurysms is fairly high. We actually had our CT surgeons evaluate him, and he was scheduled for bypass surgery and then tricuspid valve repair as well, just given that this aneurysm was compressing so much onto that valve.
So excellent case. Could you give us the main messages for the audience? Just the main messages.
The key take-home points that I would suggest from this is that, especially in younger patients who are complaining of chronic chest pain, when he was first diagnosed, he was said it was chronic costochondritis, which is when someone is having these symptoms, especially for a long time, it's worthwhile to take a look into some other less common causes, bearing in mind the clinical picture. And then the second thing is that it's one imaging modality is helpful, and that was our echo, but having different imaging modalities to properly assess what exactly we're doing. In our case, we used MRI and CT to definitively have a definitive diagnosis. It's what would lead to better management for the patient. So the right test for the right patient, basically.
Exactly. So thank you very much, Khalid Shakfeh, for your nice presentation. Congratulations for your case that you will be presenting soon at ACC Congress. And I encourage the audience to read the full case report that has just been published in JACC case report. Thank you.
Thank you so much.